It's my privilege to introduce Dr. Muralidhar Verma, who is an associate professor of Department of Infectious Diseases in Kasturba Medical College, Manipal. He was in the inception as well as in the making of department. Dr. Kavdasrao and Dr. Verma work together, and we are very privileged to have you as our infectious ID experts too. So he also serves as the chairperson of our hospital infection control committee. We create excellent output, especially in the times of pandemic. We had fantastic support from him in emergency medicine. And he has a great experience of research, especially clinical and research expertise in ID, particularly immune HIV and also bacterial infections. He has published around 79 articles in various peer-reviewed journals. We meet every day, and he supports ourselves and our staff very much in the realm of clinical management too. Thank you, Dr. Verma, for being here, and we expect to hear from you, and we are eager to learn from you.
Thank you, Jairaj. Let me first upload my slides. Can you see my slides, Jairaj? Dr. Jairaj, can you see my slides?
Yes, we can see your slides.
Yeah. Yeah. Some issue with my mouse. 1 minute. Going forward. Yeah. Good afternoon, everyone. And Jason, hopefully we'll see you next 2020 World Cup, and hopefully India will win in Australia, right? Thank you. That was a wonderful talk and a lot of insights about ICU patients. And we being in India, we are far away from reaching the goal, some of the concepts which you have taught us, right? But we are definitely working towards it. So I will be presenting something completely different. And this presentation is primarily meant for postgraduates and some of the students from pharmacy practice, trying to give you the insights of some of the antimicrobial stewardship. It's a big topic. I try to make it very simple and practical, but we can always have a discussion end of my talk. So let us look at a case, a 48-year-old male who presented to us with no premorbid illness, had fever, body ache, 4 days, breathlessness since 2 days, at admission saturation 90%, he had hypotension. On evaluation, he had ARDS, AKI, and thrombocytopenia. I think this is a very common scenario we all see during the rainy season, and diagnosed to have leptospirosis. And he was started on injection ceftriaxone and a supportive management in the form of ventilation, dialysis, inotropes, etc. So over a period of next few days, like most leptospira patients, he was extubated, he was doing well, his hypoxia was getting better, then he was planned to shift to the ward. On day 7, when he was planning to shift to the ward, his hypoxia got worse. He had a new onset hypotension. Then his clinical condition rapidly deteriorated. Unfortunately, the culture report, I think it's not shown. Can you see the culture report, Jairaj? I can't see it in my computer. It's not seen.
It's not popping.
Yeah, no problem. So he had blood, and blood was growing pan-drug resistant Klebsiella, which was resistant to virtually every drug. And unfortunately, patient expired. This is not a very uncommon scenario what we see in our hospital, and not only in our hospital, across India. Patients coming for a disease which could be potentially treated, ending up getting a disease which is almost very difficult to treat. So what we call it as hospital-acquired infections. And most of the hospital-acquired infections are caused due to, nowadays in India and developing countries, is due to pan-drug resistant gram-negative bacilli. So why do we need this antimicrobial stewardship? So that's a big question. So what does this case teach you, which is not uncommon. This is very similar case which we had about a couple of weeks back. The antimicrobial resistance currently kills about 7 lakh patients every year and predicted to increase about 10 million. That we are talking about 1 crore deaths in question of 30 years from now. That's a significant economic burden. As per the WHO data, we have estimated economy affected by the AMR is about 100 trillion annually, right? That is an estimated burden. And as you know, the AMR is not restricted to bacteria alone. It could be due to antiviral drugs, antifungal, and antitubercular drugs. But for today's discussion, we will keep it only for the antimicrobials. So what is driving this AMR? As you know, in healthcare facilities, we all know that it's predominantly the density of the patients. As a result, the bacteria they bring along with them and they transmit within the hospital. So there is it is like having a cricket match with, in Gujarat, we have a lot of people come and watch. It's a high density, huge risk of transmission. There are two areas which we will like to discuss today. One is improper antibiotic prescription in human medicine, but I will stick to predominantly in the hospital area because we will not be able to discuss the rest of the things today. And how inadequate our infection control practices are in most centers in India. And there is an overuse of antibiotics in agriculture, the global travel, poor sanitation, which is a common problem in developing countries, overprescription, lack of vaccines, drug resistance against pathogens. So there are a lot of issues which are driving it. But we will stick to two important topics today. One is the antibiotic prescription in the hospital setup. So does antibiotic sensitive mitigates antibiotic resistance? I think all my images are not coming, unfortunately. I don't know what is the problem. Right. So as you know that going back to the previous slide, when you give an antibiotic, there will be a selection pressure, right? A sensitive strains will tend to become resistant over a period of time. Even if you give appropriate antibiotic, even if you give adequate dosing, adequate duration, still there will be some amount of resistance. Question now is how can we reduce it? We can never make it zero. We can only reduce it. So what is antimicrobial stewardship? People have tried answering this question, right? Because when we say stewardship, it sounds a little bit strict, right? Steward, ward. It looks like as if somebody is monitoring you and somebody is with a stick behind you. But the idea is not that. Idea is, as you learn from my talk, that it is about working together, right? It is how do we address the issue together, right? So there are different definitions. I just picked up from the CDC Atlanta definition. Antimicrobial is globally defined any activity to optimize drug selection, dosing, duration, and the route of antimicrobial. Looks very simple. Again, as I go on, I will explain you. This is primarily at the patient level. The definition might be a little bit different if you look at country level, community level, or at the hospital level. So it's all about striking the balance between the optimization of patient outcomes and minimizing the antimicrobial resistance. Sorry, I don't know, there's some technical glitch, all my images are gone, right? So end of my talk, I want to be very clear that when you say antimicrobial stewardship, I don't want you to carry home message saying that don't give antibiotics. It's not. We are trying to save a patient, but at the same time minimize the collateral damage for the medications what we are giving to save, right? We in ICUs, especially people working in ICU like Vishal in EMD, we know that sometimes we overdo it and sometimes we underdo it what we want to do. And there is a lot of individuality which comes in. That is where understanding the science behind it and making a proper guidelines will mitigate all these issues. So as I said, AMS can be at the patient level, which will be a predominant discussion today, where we will be using empirical antibiotics, how to decide on that, syndromic treatment, PKPD, which I'm not going to touch today because I've just put them on, I deleted them because we had a wonderful talk on that. de-escalation, and IV to oral. So some of those topics I'll touch. I'm not going to talk about how to run a stewardship program, how it is interrelated to the IPC program, which are close jodis, then the structural resources we need, etc., and community level and national guidelines, which is beyond the scope of this today's talk.
Varma, we can share the slides from here if you stop sharing.
Yeah, is the images seen there?
No, not in this.
Yeah.
Right, Varma. So I
Then
think
I would prefer having here if the images are not seen, because it'll be easy for my.
No, yeah.
Images are seen, then you can upload it from there.
Yeah, we will try.
Yeah, you can just let me know. Shall I continue or I'll wait for you?
Stop sharing. We will
Yeah.
from here.
I have to stop. Is it done?
Yes.
Next.
Yeah, now it is seen actually, right?
Yes.
Yeah. So somebody is running the this one. Yeah. Just next slide, please. Next slide. Yeah, no, before slide. Before that, yeah. Is it in the slideshow now?
Yes, sir.
Yes.
Yeah. Okay, fine, right. I have one bar which is yeah, that's fine. So today we are going to discuss primarily about the patient level issues. So simple basic things, and hopefully I'll try to make it a little bit more interactive, and PGs can participate if they can put it in the chat box. Next slide, please. Yeah. So what are the components of antibiotic prescribing practices? This is the one simple slogan which is put up by the Agency of Healthcare Research and Quality, which is the research wing of DHHS, right? Which is very aptly put. The first one is making a diagnosis, which we will go into it. And as you know, that diagnosis is the only thing in medicines. Without diagnosis is nothing, right? And other thing, all patients, how culture should be done and empirical therapy should be decided, then stop whenever not required, narrow it down whenever you get cultures, and then probably give shortest duration, and then change it to oral if required or whenever it is possible. We try to drill in some of the concepts by looking at some of the cases which we have in our hospital. Next slide, please. So before we go on to the actual thing, some important concepts about the AMS and IPC are important. As you know, without IPC, there is no AMS. See, antimicrobial stewardship is about how do we optimize the antibiotics. But if you can prevent an infection, there is no question of giving antibiotics. So that's why always the aim of infection control is to create less opportunity for the stewards to do anything. So it's all about prevention. Classic example is our COVID, where you can remember exactly 1 year back how we were struggling, and there's a lot of media about second wave, etc. But now we are all vaccinated. We are almost like significantly less number of cases. Once we cross the prevention, then it's about control. That's what we were trying to do predominantly in the first wave and second wave. We already have enough infections. We are trying to reduce the spread. That's where the triaging protocols in ICU, when we put it up, how do you isolate a patient, etc. Okay, you have done all that, you still, some patients leaked on, then you start the therapy, right? So that's where the stewardship opportunities come. So stewardship always comes when the prevention and control fail. So that's a very important thing we need to understand. So you have to strengthen your IPC before strengthening your antimicrobial stewardship programs. Next slide, please. So as I said, there are Jodi, right? As you know, the 5 moments of hand wash are essential, about almost like we are celebrating the 12th year of 5 moments of hand wash, right? And similarly, the 4 moments of stewardship, they go hand in hand. They are inseparable. Next slide, please. Yeah. So some more important concepts about antimicrobials. Next slide. This is for postgraduates and some of the students who are there. As you know that there are different types of antimicrobial therapies. One is when the patient presents to you, what we give a therapy before our cultures come in or the labs come in, we call empirical therapy. Click again, whoever is running the slideshow. Can you click again? Yeah. This is empirical therapy. Yeah, slow, 1 minute. I'll just keep telling. Yeah. So after that, you send cultures, and then patient, once the culture is seen, or you got a culture and you know what is the organism, what is the sensitivity, and you go for definitive therapy, right? Any drug you give to prevent the whole infection, we call it as prophylaxis. A classic example, I would say, we give TMP SMX to prevent PCP pneumonia. That's what is prophylaxis is about. There's no actual infection, but you want to prevent it. Next click. Click again. Yeah. Yeah. The other one is preemptive therapy. You have a high risk patient who likely to have infection, but you don't have a proof for it, but you have an indirect evidence, either in the form of say an antigen which is positive, or there radiologically which is positive. You want to treat that infection, something. It's typically we use this strategy in high risk patients, like in oncology patients. Ultimate goal for a good clinician is majority of our empirical therapies should convert into definitive therapies, right? If you are successful in that, that means your stewardship program as a clinician, you're doing a good job, right? And how do we guide clinicians to achieve this? That is one of the important goals of any AMS strategies. Next slide. Yeah. If you look at a patient coming to ED emergency or coming to OPD, for all practical reasons in infectious disease, there are multiple syndromes, right? To help us identifying the potential antibiotics which we can use or when not to use. So this is a very important concept all clinicians should know, practicing physicians should know, because if you want to use stewardship or guidelines, ultimately you need a syndrome, right? Otherwise, it's difficult for you to follow what the recommendations are. So this is the first step you need to know. So I just put it up as a commonest ones. This might change in different, but we have a unique problem in countries like India where we have tropical infections, apart from respiratory, GI, urinary, CNS, skin, soft tissue, and others. So many times we end up giving a couple of extra antibiotics because at that moment we are not sure. Unfortunately, there are no international guidelines recommending this, and there is no good data to help us out. But it is over a period of experience, we have seen that during the peak season of tropical infections, we end up giving additional drugs. So this is where we feel that the local anti-stewardship program should evolve, which, as Jason said, they don't see much gram-negative pan-drug resistant organisms. So that's where the local data becomes extremely important. Go ahead, next slide. Next slide, please. Yeah, so this I put it as, go back, 10 commandments of the antibiotic treatment. This is how I use it, but you can use it anyway. First question you ask is the patient having infection? Second is, what is the clinical syndrome is having? Okay, you have an infection. Is it bacterial, viral, fungal, protozoal, right? If it is viral, you don't need an antibiotic. What is the clinical severity? That decides where the patient goes and how aggressive treatment. How to optimize your empirical therapy. Route of administration, that again depends on severity. Is the patient having drug allergy? Did you take a good history? And then, of course, narrow down at the earliest, plan the duration up ahead, follow some guidelines, and then finally, if possible or if required, change it to oral. Some of these important questions we will try to address today. Next slide, please. So just to reiterate again, ultimately it boils down to diagnosis, right? That's why I keep telling always, if you have a diagnosis, you can just open a textbook or you can read anywhere and treatment is out there. You don't need. The question is, what will you do interim before the diagnosis is done? That's where your clinical skills are very important. Go ahead. Next slide. Yeah. So we'll discuss some of the cases addressing some of these issues. I didn't cover everything, but some of the important concepts I tried to cover. This is just a picture trying to show how we practice when we practice clinical medicine. Again, these numbers are just arbitrary. These are no reference for this. This is just out of my experience. I put it up. 60 to 70% of the cases what we see in ICUs and ward have good clinical correlation with the lab or better clinical outcome. Over a period of time, I'm finding actually this percentage is dropping because more and more complicated patients are being referred or the hosts are becoming complicated. About 20%, can you click once again? Just click one, yeah, next, that's stopped. So other one is good clinical correlation, lab correlation, but patient does not make out, okay? That we have seen, like the patient which I've shown you, we made a diagnosis, everything is fine, patient passed away due to high. Next click. In some situations, poor clinical correlation, but still patient outcome is good. This is a wonderful thing for all of us because we take credit for all these patients, right? Because the patient does well and they come and say, thank you, doctor, you did well, but actually you did bad clinically. Last one is even worse. You have no clinical correlation. You don't know what is happening, how to correlate, and patient outcome. So I'm not going to discuss about the last three. We'll stick to the first one, that is good clinical correlation and lab correlation, and patient outcomes will be good. Go ahead, next one. Next slide. Yeah. Let us start with simple thing. 20-year-old student comes with cough, fever, running nose, sneezing, body ache, 2 days, and no history of wheezing or dyspnea. There's no significant past history. On examination is febrile, heart rate is high, BP is normal, respiratory rate is normal. He has posterior congestive walls, a mild congestion. Otherwise, rest of the systemic examination is normal. So what's a working diagnosis? Can any PG put up in the chat box? It's a straightforward case. I think PGs can put up in the chat box. What is the syndrome we are looking at? Just try to identify the syndrome rather than making a diagnosis. Don't jump to the diagnosis straight away. I think in the era of COVID and influenza, this is a very straightforward case. Anyone there? I can have a look at the chat box. Yeah, I'll give a few seconds. Any of the postgraduates or students can answer this? Okay, we'll go ahead. Next slide, please. Yeah, so this is a clear-cut case of upper respiratory tract infection. So we have identified the syndrome. This patient having infection, that is rule number 1, commandment 1. But the first thing you should realize in majority, more than 90-95% of upper respiratory tract infections are due to viral. So the 4th commandment, that is, you don't need an antibiotic for it. So you, if at all, you need an antiviral, right? So overall viral pathogens, predominant cause of pharyngitis. And this is one area where antibiotics are grossly misused. It's very, very unfortunate that we use a lot of antibiotics, even mild cases of COVID, which was absolutely not required. Tons and azithromycin and doxycycline were used. So sad. We can use a simple clinical scores like center score. With the help, we can differentiate whether it's a bacterial or not, right? Are the investigations required for this patient? Probably yes. A swab is required to say for COVID and as well as influenza nowadays. Previously, it would have been only COVID. Go ahead, next slide. Yeah, not required. Antibiotics not required. Somebody has correctly answered. So this is again, just to reiterate again, this case does have an infection. Site of infection is respiratory, predominantly upper motor. Upper respiratory. Cause of infection is viral, right? So it's important that to identify. So rest of the questions actually does not matter now. So we can stop the discussion there. So this patient requires, if at all, if you think suspecting influenza, you can put the patient on oseltamivir. Next slide. So message, antibiotics don't kill virus. So don't use antibiotics if your clinical syndrome suggests that it is a viral infection, right? So that's a very important message you need to know. Majority of upper respiratory infections do not require antibiotics. So please don't misuse them. Next slide. Yeah, we'll go on to the next case. That is a female diabetic, glyco-HB of 9, totally uncontrolled, fever, burning exertion 6 days, low backache 3 days. On examination, patient has hypotension, pulse is high, high-grade fever, light loin pain and tenderness is there. What's the working diagnosis in this patient? This is a pretty straightforward case. What's the diagnosis? Anyone? Somebody has written urinary tract infection. Can you be better than that? Correct. Your syndrome you have identified. It's predominantly affecting the urinary system. Can it be better than that? Patient has hypotension and has fever. Fever in a UTI, hypotension are unlikely to be lower UTI. So it has to be an upper UTI. So these are the two clinical markers. Of course, there is also complicated UTI. Yeah, fine. Somebody has written, but I would say pyelonephritis or upper UTI is a correct answer. So the diagnosis is that. So do we need an empirical antibiotic for this? Next slide, please. Yeah. So this is the next question. Before we start antibiotics, it's very important that you draw cultures. So that's what we call culture of cultures. So we tend to monitor them, right, and see how cultures have been drawn. So we are encouraging people to draw cultures. If you don't draw a culture, how will you change your empirical drug to a definitive therapy, or how will you narrow it down? So doing cultures is of utmost importance, especially when a patient is having a syndrome of systemic infection. Like in this patient, what cultures will you send? In patient like this, what cultures will you like to send? Next slide, please. What cultures will you send? Any PGs? Yeah, we like to send for blood because we are expecting bacteremia, and then probably urine culture. Absolutely right. Somebody has written correctly. So message is send cultures whenever clinically indicated, up ahead before you start antibiotics. Next slide. Yeah, so in this patient, clinical syndrome is urinary tract infection. We can go one step ahead and say it's pyelonephritis. Next slide. So how do you choose empirical therapy? This is a tough question to answer. So now your first step to choose an empirical antibiotic is always identifying the clinical syndrome, right? That's utmost important. So how do you identify clinical syndrome? Good history, examination, and basic labs. Once you identify a clinical syndrome, then you can guess what is a likely organism and also probably guess the resistance pattern. We'll not go into too much details of it, and then also decide on what is the route of administration. So I'm not going to about the resistance pattern. We will stick on to the simple organism. So how do you choose? That's always difficult, right? Next slide, please. Yeah. So can we use a local antibiogram and then antibiotic policy, or shall we use national or international? That's where the debate is. Next slide, please. So let me start with a simple thing. So if you read Davidson, like an undergraduate, for the same syndrome, we are supposed to use coamoxiclav or ciprofloxacin. So how many of you sitting here will agree I will give coamoxiclav for this patient? Means none of the clinicians will use this, right? Even though it's a standard practice probably in UK, because their resistance pattern in their community is different than ours. So obviously we should not use standard textbooks to decide about the antibiotics for empirical therapy. Go ahead, next slide. Next slide, please. Yeah, can we use a national guideline? So national guidelines says Pictaz or ertapenem. Probably it's not a bad choice, but again, subtle difference will come. So next slide. So guidelines are always confusing. So guidelines, we often think, is it correct? Is it wrong? Because how is it not matching up to what I am seeing and why the clinical outcomes are so different, right? So how do you answer this question? How do you solve this puzzle? Next slide. That is where it's important that every hospital or local area start doing antibiograms. Okay, understand the resistance pattern within the hospital. That's what we call it as think local always. Infectious disease is one branch where local data is far more important than any international data, right? We can, for cardiology, for neurology, probably you can use guidelines. but here everything is local. So it will give us a resistance pattern. Just go ahead, next slide, just to give a snapshot about this. Go ahead. So this is how an antibiogram looks like, where organisms will be given sensitivity patterns. They keep changing. Next slide, please. And then based on that, antibiotic policy is created. Next slide, please. So just to give a snapshot again, if you go by KH antibiotic policy, we are saying cephalosporin sulbactam. Of course, part of it is cut here, some slide issue here, right? So next slide. So the idea is, when you start empirical therapy, start smart. So how do you say you are smart? So use local data. If you don't have a local data in your hospital, try to use the community data, look at the net and see, or probably state or national. That is the way. But if you have a local data, they are anytime better than national or international or even a standard textbook. So that's a very important concept when you start empirical therapy. Remember that when you start empirical therapy, your focus is to save patient. We are not unduly worried about resistance at that time, even though it's back of our mind. But our importance is to save the patient. Remember, all these patients are quite sick, like a lady I described. Go ahead, next slide. So day 3, culture report has come. Go ahead, next slide. So here, blood is grown E. coli. Are you expecting this organism? Absolutely. E. coli is the commonest for 70 to 73% of all the cultures of urine. UTIs are due to E. coli. So we expected, and here you can see that even though we started cephalosporin sulbactam or pictazo, we see that it is sensitive to third generation cephalosporins or even say ciprofloxacin. But because it's a bacteremia, we prefer using beta-lactam group of drugs. So what do you want to do then? So you step down to ceftriaxone. That is what was done for this patient. Go ahead, next slide. So your empirical therapy has become a definitive therapy now. Not only you did that, but you've gone one step and you've actually narrowed down your antibiotic choice. Go ahead. So the important thing you need to, next slide please. It is important to realize that we could be able to do that because we did cultures up ahead and we had a good clinical correlation with the labs and we had a good clinical judgment. So that all this will contribute to our stewardship program. So make sure you change the antibiotic after culture. If cultures are not there, again, it's a challenging thing, then probably you should go back to your standard guidelines. And additional antibiotics you can always stop and always narrow it down. Next one. Next slide, please. So there are a lot of de-escalation. There's a lot of advantages of de-escalation. Like you can reduce the selection pressure, you can reduce the length of stay, you can reduce the drug side effects, the cost. There are a hell lot of advantages by de-escalation. So it's a very important concept to reduce your selection pressure on antibiotic resistance. Go ahead, next slide. So start smart, absolutely correct, but draw cultures, then focus. That's a very important concept you need to understand. So the moment you get a cultures, focus down. But in reality, about most clinicians will agree 40 to 60%, depending upon where you practice and how good is your lab, we don't get culture. So what do we do then? Then we go by your clinical judgment. So, but that will encourage you, how do you improve your culturing rate and how to improve your labs? Go ahead. Next slide. So this I'm not going to cover, right? So I've hit all my slides. So we will go on to the next slide. Yeah. So here one more case, 57-year-old female, cough, sputum, fever, right, pleuritic chest pain, 5 days, diagnosed as severe community-acquired pneumonia and started on pictazo. On 5th day, patient was asymptomatic, labs got better, chest x-rays improved. So here we have already marched on quite a bit. So is this patient having infection? Yes. Where is the site of infection? It is pneumonia, so respiratory. We said it is bacterial. Then we chose your empirical antibiotic. Then we have decided that we will continue it till the patient is better. So we have already reached commandment number 6 or 7, right? So now question is, patient is getting better. how do you decide the duration of antibiotic? How long will you give? So some of the PGs can answer this. This is a clear-cut case of community-acquired pneumonia. So what do you think, the PGs? How long does this patient require? Shall we stop antibiotic on 5th day because patient is much better, probably all set to go home and is asking? Anyone? Medicine PGs or somebody from ED? What should be the duration of antibiotics? 7 to 14 days. I mean, that's a huge range. I mean, it's like Kashmir to Kanyakumari, I would say. It's too wide. 7 days. Okay, fine. That's more. Yeah. So world is actually moving to shorter and shorter regimens, right? Because there's more and more evidence and convincing data coming that shorter regimens are as good. And science-wise also it makes sense because most of the bacteria would have died by the time you've given 4 to 5 days. It's actually the effects of the inflammation what you're seeing. So we don't need that long antibiotics. I think in various syndromes, the data is coming. Can you go for the next slide, please? I have about 5 minutes. Yeah, so don't go by 7, 14, 10 rule. Remember, these numbers are thrown into our textbooks because the studies were conducted like that. There is no rationale about that 7, 10. You can stop an antibiotic on 9th day. Nobody stops you from doing that. So it's all again clinical judgment and data. You can stop it on 4th day. You will be surprised to look at some of the recommendations for duration of antibiotic. Next slide, please. So this is again American Thoracic. They recommend only 5 days to 6, 7 days if the duration, if the patient is clinically stable, right? It's a very wonderful document. People who are interested can look into it. Next slide. Some data which is showing there, even for bacteremia, they're saying it's only 7 days, right? So people are moving in all syndromes. Remember, these are bacteremic patients, which we were all taught bacteremia don't be less than 10 or 14 days. Okay, so things are changing rapidly. So longer duration is a driving force for AMR. Next slide, please. In fact, there are studies looking at 3 days. Okay, can you believe it? It's just 3 days of antibiotics for pneumonia, right? So it's always question yourself whenever you're prolonging your therapy. Again, clinical judgment is important. Patient should be clinically stable. Don't go by just guideline. Okay, this evidence shows that I'm going to stop it. You balance out your patient outcomes with AMR. Next slide. So shorter is better and in fact safer also now. Next slide. So just to complete the last few slides, 36-year-old fever, pain in the right leg, pus discharge on evaluation, severe skin and soft tissue infection. Remember, this patient has discharge. So if you go by any guidelines, a pus discharge, skin and soft tissue, we should always cover MRSA. So this is definitely an infection. This is a bacterial infection. Patient requires therapy and patient requires MRSA. So patient was started on vancomycin. Go ahead. Next slide. So then patient was afebrile, vitals are stable, is tolerating orally. Can we switch on to oral tablets? Yes, definitely we can switch on to oral therapy because we have wonderful oral available now. Patient is clinically stable. So switch to IV to oral is a very important option. There are a lot of advantages for it. Next slide, please. Here we can switch to clindamycin. Like it lowers the cost. It reduces, for me, from infection control point of view, it reduces line-related infections. We can discharge the patient. So even administrators are happy. So a lot of advantages, but you need to select your patients. Go ahead, next slide. This slide just illustrates, next slide, please. This slide illustrates, go back one slide, please. This slide illustrates you the bioavailability. So when you choose your oral antibiotic, make sure you choose it appropriately. So is it available in your country or a locality? Second, is it appropriate for that patient and the organism? That's a very important question you need to ask, right? This is just a graph showing all the details of it. Next slide. Yeah. So one more patient, a 45-year-old male, CKD, diabetes, high-grade fever, chills, 5 days, right lower limb cellulitis diagnosed, hypotension. So then pulse was high, diagnosis, Again, skin and soft tissue infection, severe form. What should be the antibiotic? Again, here it is cellulitis. So we tend to treat streptococcus. We may not require MRSA cover in this patient. Go ahead, next slide. So patient was started on ceftriaxone. So, and the blood turned out to be streptococcus as expected, and it is sensitive to ceftriaxone. The problem is next. Go ahead, next slide, please. Then immediately, as you can see, patient developed a rash, right? You developed a significant rash in the hands, body, intense itching on day 2 of ceftriaxone. Even though we expect the ceftriaxone to cause, sometimes the delayed reactions are known to occur with beta-lactams, but drug allergy is a big challenge for us. Next slide. So penicillin allergy is there, but I feel it's overestimated in countries like India. It's difficult to diagnose, right? It's reported about 10%, but I feel, I mean, majority people agree that actually, if you look at some of the statements by CDC, it's an overestimate, but it's an issue. For a mild to severe reaction, or it can be immediate or it can be late. So all these are possible. Don't think that you give a test dose. If test dose is positive, patient is going to have a reaction. It may not work out that way. It all depends on what is mediating the allergy. A detailed drug allergy history is very important. I put that in my 10 commandments. Look, ask for a simple drug allergy. The problem is patients' allergy means it could be anything. It could be due to dust, pollen. So they will say that. I mean, all of clinicians, we have wonderful experience with the radiologists always cancelling our CT scan. They said he has an allergy, and humpty number of times we ended up giving steroids. I mean, that should not be that aggressive history, but it's a good thing to ask before you start, especially beta-lactams, drug allergy. And other thing is, I think the test dose is being used for ages. I think we are overusing it. For beta-lactams, probably yes. For non-beta-lactam antibiotic groups, I think we should slowly come out of doing test dosing, right? Anyhow, that's a subject some other day we can discuss. And look for an alternative to drugs. Next slide, please. So message, inquire about drug allergies. So these are some of the important messages you should know. Next slide, I think I'm almost done. Yeah, in summary, this again tells you, except one or two, the important messages when you take a decision to start an antibiotic. The first most important, as I told you, make a diagnosis, make a clinical syndromic diagnosis, right? That's very, very important. Diagnosis will direct you what to do next. Okay, as I said, diagnosis is the only thing in medicine. Obtain cultures whenever it's important. Start empirical therapy and start antibiotics only if it is indicated. It's viral, please don't start antibiotic. Stop it whenever not required. Narrow it down as early you get a cultures. Change to oral. Duration, keep it as short as possible. Go by clinical judgment and standard guidelines. And of course, ask for allergy. Next slide. Yeah, so if you want to be successful, theoretical part is fine, but you need to have a good team with you. You need to make friends. You have to be a role model. Work as a team. What concept we say is don't work vertically, right? Work horizontally. That means everybody is equal and work with a passion. So infection prevention and AMS, you have to have a passion because there are a lot of hurdles for all this, because we need to tackle a lot of people to convince what you're trying to tell, right? These are very important concepts we need to understand when we run a stewardship program. Next slide. So just to end, Alexander Fleming got Nobel Peace Prize in 1945. So he gave a very important statement. I'm sure all of you know about this. The time has come when penicillin can be brought by anyone in the shops, which we are here right now in India. Then there is a danger that ignorant man may easily underdose himself, PKPD, he knew that time, exposing to the microbes to non-lethal quantities. That means subnormal doses of drug and make them resistant. So this was predicted almost like 70 years back, right? Phenomenal. Next slide. So I like to end with just like we have carbon footprint, we have antibiotic footprint, right? So let us join together to reduce antibiotic resistance and always work together with prevention, right? Prevention, then only the treatment. Thank you very much. Next slide, please. That's the last slide. Thank you. If there are any questions, I will like to take.
Thank you very much, Dr. Verma. As always, you had very important, very important keywords and notations, which is very important take-home points for the postgraduates and also the pharmacy students out there. It's very important that there are certain points you already mentioned. What are things you will be looking for once you're starting your practice? One is you have an antibiotic steward program. What is your antibiogram? Who's your ID expert? Or how you're going to work your team? These are important things for any aspiring young clinicians who is really wanting to save life from the patients who are already infected. So the most important thing, if I'm taking the take-home point, will be that antibiotic footprint, because that is a very important keyword I will take probably, which I will inform my students here. And I think it's very important that, as a human being and as a practicing clinician, we have to be very clear that there is not much antibiotics in the pipeline, and there's $1 million research which is going futile because of our misusing in the poultry to aquaculture to so many other things. And being responsible clinicians and pharmacy experts, we should always be very clear about what we are doing is right practice. Thank you very much. I would like to have some questions from the students and audience here, and we can have it in the chat box, and Dr. Verma probably will deal with that. One more point I wanted to make here is the culture of culture, right? To how you are taking the culture and how you are, the whole process of doing a culture is as we would like to emphasize, because there's no, once you're shooting an antibiotic, then trying to take culture, probably the timing is completely wrong. You almost made the patient survival a half chance, right? So over to the students, and we will take some questions here.
I think there's one question.
Yeah, there's one question. How to convince clinicians to have shorter drug durations when there is no clear guidelines? Or
one single strategy will never work, right? I think you need time and you need a good team. So one thing we understood in infection control also in the last 20 years or so I've been working, right? You have to show results. So don't try to replace them, right? Be partner with them, show that you try this strategy, it will work, right? That is the mantra we have always been trying. You don't try to compete with them and try to dominate them. That is the first thing, right? The strategies used in West will be completely different than Indian doctors, because data you can produce that will help us, because that will help us convincing ourselves first, and then it will help you during the discussion with the clinicians, right? But ultimately, a clinician will listen to you if you say that you use a shorter duration, and look at in some patients you try. That is how we enter into their mind, right? Like for example, even for some of the surgical units when we were working, we said try. So that brought out some change. I still remember there was a lot of hindrance even to send blood cultures initially because of the cost constraints. Now, in fact, we have gone to the other end that we are doing too many blood cultures to my comfort, right? And our contamination rates are very high. So both are extreme, but ultimately, I think where you practice is a strategy. So my strategy has always been a partner with them, show them results during discussion so that there is one. Don't ever be above them. Then the whole program will collapse. Never try to dominate anything. That is the way it works. So it might be completely different in the West. When I went to Australia, US, or in Europe, they look at data, right? You present data, then I'm sure Vishal might know because he worked in Oman. So they look at data, then they like, and of course, this thing. Actually, there are a couple of very interesting articles published about a year back in CMI, Clinical Microbiology and Infection, where how to run a stewardship program. The one which got highest confidence, highest odds ratio was interpersonal relations. So interpersonal relations have a huge impact in running IPC and AMS programs. So you need to have very good interpersonal relations to run your program. In fact, p-value was very significant. I still remember reading that article. So no single strategy.
Any further questions from audience?
I can see one more. There's some confusion regarding duration. In Saudi Arabia, we use 7 days only. I think that was with context of the CAP, I think, community acquired pneumonia. Yeah, I think it's correct. Vishal might add, I have not worked in Middle East. There, I think the stick works very well. The ministry runs the whole show. You can't just beat them. In India, we run in a democratic country. So 7 days means it's 7 days there. At least I don't know. That's what my friends told me. Is it right, Vishal? You can't be 8th day.
Actually, there is a clinical pharmacist and pharmacy in charge who will be supervising your prescription. Okay. And they are given clear-cut guidelines who can prescribe what antibiotics. So if as an intensivist, if I prescribe a broad spectrum, piperacillin tazobactam, by next 3 days, I must get an approval for it to give for the next day. So if I don't get an approval, even if I write a prescription, the pharmacy will not dispense the medicine dose. It is that strict in some places, but I think, as you rightly said, it
what
depends
happens.
on
the clinician makes noise and
no,
say,
no, I want no. Even if he makes noise, they will not give.
Okay, what do you do if there are long holidays? Say Ramzan.
No, whatever it is online system. Nobody can say I'm not on this online system. Nobody can bypass it.
So at least in Europe and US, it is a little bit laxer. There is a teamwork.
We can always convince our colleagues, like as you said, communication. So sometimes we were not convinced about stopping it immediately because patient was still sick. So we used to have a online chat or call the ID and discuss probably this is not the right time to de-escalate. Let us wait for 2 days or let us wait for clinical recovery. And obviously they used to oblige because that is how you, as you rightly mentioned, the most important point is relationship, and probably that's what helps you in guiding. Yeah. So obviously they used to oblige, approve for 2 days, and then when everybody is convinced that okay, it's not required, we used to stop. And we never used to follow 7 days. We used to stop for 3 days, 6 days, 9 days. So whenever you feel
there is no uniform pattern. Yeah, I agree.
So no mantra of 7 or 10 days. No
similar system in US. I think they sit and partner out. But what I understood, usually in some Western countries, the clinicians dominate the pharmacists. It all depends on how senior the pharmacist is. Yep. Right? Somebody like Jason, probably they have to listen to him because he's too senior and he has 450 publications. You can't question him then, right? So, and somebody who's just joined now is that, who are you? Get lost, right? So I think it's important to understand the small things when you run programs, right? But working as a team, as you rightly said.
One more point would like to put here is the drug-induced fevers with antibiotics itself, and also you already mentioned that the inflammatory process will outlive the bacteria, and you may be having fever. So probably a bit more mention for the young students out there who is going to be the next clinicians.
Yeah, I think some more questions are there.
How to determine the optimal time duration for antibiotics is from Sriram. So probably it is the same line.
Any idea about antibiotic use and resistance, laboratory and pharmacy? Yes, who is responsible for it?
AUC maybe.
Means they're trying to ask who will be responsible, the lab and the pharmacist working together. That is what they're trying to ask. I'm not getting that. Dominic.
Is mentioning the area under the curve? AUC?
No. I don't think so. Resistance, area under the curve. I don't know. I'm sorry, Dominic, I'm not able to get you, but I'll take the next question. How to determine the optimal time duration? I think I've already mentioned that. I think the world is slowly growing from standard 7, 10, 14 regimen like that, and more a clinical judgment. When you say clinical, it is your vitals, your site of infection improvement based on radiology, etc., and your inflammatory markers. And then finally, your hospital protocols. I think if these 4 are in line, you can stop. So that's what is optimal therapy. But worldwide, there is a tendency in all syndromes to become shorter and shorter regimens, right? Including tropical infections. Then for leptospira, actually, there's a debate whether we really need an antibiotic. Most of the time, we don't need more than 4 to 5 days. Yeah.
I think even the biomarkers will help us to determine
a lot of improvement. But as we are taught in first class, no single stick, we can break all 6. So it's together everything. Don't use only procal. Procal is negative, everything is all right. I mean, That's, I think Vishal knows how many patients we burnt our fingers like that during COVID. Yeah. So let us not use only one thing and say everything is fine. I don't know. Dominic, can you explain that question? So I didn't get, in Saudi Arabia, they use AUR for pharmacy and laboratory, who is responsible to do antimicrobial use and resistance. Vishal should take this. Probably it's all how the ministry runs.
No,
exactly what you are telling, right?
I'm not able to get the word AUR.
It's area under the curve, maybe for the.
No, it's not under area under curve. I think anti-utilization rates.
Okay.
It is antibiotic utilization rates.
Yeah.
So I think pharmacy and lab determine, right? As you said, right? It's not the clinician alone. The pharmacist will go and talk to the lab and they look at the resistance, microbiologists, and then talk to the clinician. This is what we decide. If you agree, you do it. Otherwise, we have a discussion. I think that's what it is. We don't have such system. We are a long way to go, right? Because of various reasons how Indian healthcare system works, right? So everybody is responsible. As you said, who is responsible? I think clinician is topmost priority for deciding on the resistance, right? And we are all part of the same group. But we don't want to lose patients like what I've described, right? So it's a very common scenario now, losing patients due to pan-drug resistant gram-negative bacilli. I think it's 5 o'clock. Are there any further questions, or Kavita, you want to continue?
No, I think we can conclude the session. I thank the speaker, Dr. Verma, Dr. Jason, and the moderators, Dr. Jairaj and Dr. Vishal, for the excellent program. We would like to play a video before I move on to tomorrow's program.
Take a photo.
From that side.
We'll take it.
I thank all the participants who have been very interactive and have attended this webinar. For tomorrow, the program starts at 4 o'clock. We have an exciting quiz. We have 5 people who have been selected. Dr. Manish Kumar from Government Doon Medical College, Dehradun. Dr. Ankit Mittal, All India Institute of Medical Science, New Delhi. Dr. Rahul Garg, Indian Institute of Liver and Biliary Science, New Delhi. Dr. Siddharth, KMC Manipal. Dr. Rohit Gupta, ESI Hospital, Delhi. So all 5 participants will be involved in the quiz. So I request many delegates to join and encourage the participants. There will be an exciting quiz program to start at 4 o'clock tomorrow. Until then, goodbye. I request all the panelists to switch on their videos for a photo shoot. Nitin Gupta. Thank you.
Thank you.
Thank you. Thank you, Dr. Kavita and Dr. Verma.
Thank you very much.
Thank you.